This week, our topic is on neurological disorders. So, we're going to be talking about any disorder involving the nervous system. And this can include abnormalities in the brain, spinal cord, and other nerve damages. On the back of the medical history form, towards the right-hand side is where you'll find the neurological conditions. We're going to be focusing mostly today on epilepsy and seizures, but we'll also talk briefly about sleep disorders, mental illnesses, Parkinson's disease, and Alzheimer's. The first neurologic disorder I'm going to talk about is seizures and epilepsy. So a seizure is when a person has a sudden surge of electrical activity. So there's some abnormal electrical charges going on and chemical changes in the brain and in the nerves of the brain. And that's going to impact how that person acts or appears for a very short period of time. Seizures can happen to anyone for a bunch of different reasons. It doesn't matter what gender or race you are, they can happen to anyone. A few of the reasons that people can get seizures are from brain injuries. They can be genetic, so this could be something that their parents have or a genetic condition that is new to their genome. It could be the result of having a stroke and brain damage after a stroke. It could be from a brain tumor, and there's a variety of other causes as well. Usually seizures are unprovoked, unpredictable, and involuntary. So when a person is having a seizure, the movements and the words that are coming out of their mouth, maybe these odd behaviors that they're doing are totally involuntary and unpredictable. You don't really know how every seizure is going to turn out for someone. And because the nature of seizures have to do with what lobe of the brain is involved, they're different in everyone. So some people might have a certain lobe of the brain that's affected by seizures, and that will make them do certain movements with their hands versus someone might do other movements with their lips, or they might have changes in their personality, or they might say a certain word repeatedly. So sometimes people like to use seizures and epilepsy synonymously, but the actual definition of epilepsy is someone that has two or more seizures with spontaneous reoccurrences. So if someone just has one seizure in their lifetime and never has another seizure, then you wouldn't classify them as an epileptic person. So that the definition of having epilepsy means two or more seizures that spontaneously reoccur. Here's some facts that I found on the Epilepsy Foundation website, and I thought that they were kind of interesting, so I decided to share them with you. The first one in 26 people in the United States will develop epilepsy at some point in their lifetime. And I thought this was kind of a really crazy amount of a number that I did not think I would have not guessed that if someone would ask me what I thought the percentage was. So it is rather common. I do believe that this statistic is including a lot of children that have epilepsy as children and grow out of it. So we may have never known someone to have epilepsy in their past, so maybe that's why the number seems so large. But I did think that was interesting, so I decided to include that. Another one, about half of people who have one seizure that does not have a cause will have another, usually within 6 months. I thought that was kind of relevant to us as dental hygienists, because if we hear about someone having a seizure, having one for the first time, and it's within 6 months and we're seeing them, there's always that chance that we could see a seizure happen with someone that's had one 6 months ago. If there is a known cause for your seizure, so if you've had a brain injury, a stroke, some kind of brain condition, then you are twice as likely to have another seizure. And then if you have two seizures, there's 80% chance you'll have more. So I think that's where the epilepsy term comes on to, because if you have two seizures, you're more likely to have more, and this is a chronic condition such as epilepsy. How How neurologists test for epilepsy and seizures are called an EEG test, and this is electroencephalogram. And that's what they study to see what kind of brain activity is going on and help them determine if they can predict whether there's more seizures going to happen. And another thing I wanted you guys to know is that it's most often diagnosed in children under 2 years old and adults 65 and older. So we're on both ends of the spectrum. We have the really young and the older population. I talked a little bit about causes of seizures, but I'm going to break it down even further. So about 70% of seizures are idiopathic, meaning that there's not a known cause for them. These idiopathic epilepsy, or what they call primary epilepsy, tends to occur between those younger years, so diagnosed between 2 and 5 years, and then again at puberty. And this also tends to be genetic, so there's not a known cause other than something in the genes. This could be inherited from their parents, or it can be new to their genes as a person having a genetic abnormality. And then the second cause is called acquired epilepsy or secondary epilepsy. So this is something that's acquired through their lifetime. It's not genetic. So it's caused by something externally, some kind of event or a disease. So a lot of times during pregnancy or during birth, there's some events that can cause someone to have epilepsy. So while the fetus is growing, any kind of fetal alcohol syndrome or drug use, if there's any excess toxins during the pregnancy, or if the mother has any infectious diseases, so something like syphilis. Injuries during birth, so if during the birth it's a complicated birth, they have to use forceps. If there's a lack of oxygen, if there's an umbilical cord complication, or excess pressure on the head, that can be an external event that could cause secondary epilepsy. A traumatic brain injury at any time in life. So if someone is in a car accident, I knew someone that had a traumatic brain injury from getting in a mountain bike as they were hiking, a mountain bike crash. So any kind of injury to the brain, I'm sure there's a lot of traumatic brain injuries in sports as well. Infectious diseases to that person, such as meningitis or syphilis, and then something like a brain tumor if the person gets a parasite or stroke, like we talked about earlier. Sometimes, not all the time, but sometimes a person with epilepsy will have what's called a seizure trigger. And this is a seizure that has a pattern to it, or it's more likely to occur with certain situations or certain occurrences. So this is a factor that may precipitate or come before a seizure. So I want you to know and know the difference between the cause of a seizure or cause of epilepsy being something like a brain injury or difficulties during birth, or it can be a genetic condition. But a trigger is something that, the person already has epilepsy, and the trigger is something that just sets off a seizure. So there's a lot of different kinds of triggers, and some that can be found in the dental office. So it's really important that if we're able to identify, or the person's able to identify their trigger and let you know, what their triggers are, you can be prepared to prevent the case of someone having a seizure in your chair. So again, the seizure trigger is not the cause of epilepsy, it's just what might set off a seizure. Like I said, there are a bunch of different seizure triggers, and I highlighted some of them that are more likely to occur in the dental setting. So, photosensitivity. So, this is something that we really might do a lot of during a dental appointment. Blinking lights, flashes of lights, if there's a TV in an operatory or a computer monitor, there might be combinations of the moving lights, the colors, and the sounds. So that can be a seizure trigger. So when you have someone with a seizure disorder and their triggers photosensitivity, we're really going to have to be cautious with these people using our headlights. If you're using a headlight or the overhead light and you're moving it, cautious not to get it in their eyes and be a cause for that seizure trigger. Another one that we might see a lot of is stress and emotions. So we want, if that's their trigger, is being stressed or feeling emotional, we need to know that so that we can employ those stress reduction protocols. And then other ones that are not as common, but something that we could do to someone to trigger a seizure. If someone didn't eat or they have low blood sugar, if that's their trigger, we're going to make sure, did you eat this morning? Do you check your blood sugar? And loud startling noises. So we do have a few items in the dental office that cause loud noises. A lot of times that would be more on the dentist end as well, with the drill, if they needed a filling or something like that. And then an unexpected tap on the body, especially the head. So that is something that we could do by accident, accidentally tap or knock into someone's head. So if that would be the cause, again, you'd have to be really cautious of that. There are many different types of seizures, and I want you guys to be familiar with the most common ones. I'm listing 6 here, but there are probably 15 to 20 different types of seizures because they get really specific. And the information I'm giving you today is current as of 2017. So the Epilepsy Foundation is constantly changing the naming of different types of seizures. So right now, you might not have heard some of these seizures, but you might have heard some in the past named differently. So we'll talk about what they used to be called, but for our class, we're going to use the most current terms. So first, the types of seizures are split into 2 different groups. So we have focal seizures and then generalized seizures. And these are separated by which areas of the brain that they affect. So focal seizures make sense. They're focused. They are confined to a small area of the brain and usually only one side of the brain. And focal seizures were formerly known as partial seizures. And the 2 seizures that fall into this category are focal aware and focal impaired awareness, and we'll go through those. And then on the other side, generalized seizures, these affect both sides of the brain. So we have tonic-clonic, myoclonic, atonic, and absent seizures. And you might be familiar with a few of these. First, we'll talk about the 2 types of focal seizures. Remember, these used to be called partial seizures. The first one is focal onset aware, and this used to be known as a simple partial seizure. It affects only one side of the brain. And remember, these focal seizures are focused. They're small areas of the brain. And the important thing to note about a focal aware seizure is that there is no loss of awareness. So this person's fully awake, they're alert, and importantly, they're able to recall the seizure. They're able to recall not being able to respond and just kind of having this seizure. They can recall if someone said something to them during it. So these people may look like they're frozen, and they might not be able to respond to others. So someone might be talking to them, and all of a sudden the person kind of freezes and they aren't able to really move, they aren't really able to respond or talk, and they just they kind of look like they're daydreaming and they can't snap out of it. And these seizures are pretty brief. They usually last less than 2 minutes. So this is very different than what most people classically think of as what a seizure is. Just pretty much daydreaming and frozen. And then the next one is focal onset impaired awareness. These were known as complex partial seizures in the past. Again, these are only affecting one side of the brain, but in this type of seizure, there is a change in the level of awareness. So there's some kind of impaired awareness. During this, there can be some involuntary movements, something like rubbing the hands, lip smacking, chewing movements. If they're if they're laying down or if they're sitting, there might be bicycle movement of the legs. Again, these are often brief, lasting 1 to 3 minutes. So we're really under the 5-minute mark for both of focal seizures. Important to know about these types of the focal onset impaired awareness seizure is that it can be a aura. We'll talk about what an aura means in the next couple slides, but it can be an aura in a something that tells someone that there's about to be a convulsive seizure coming. So it can spread to both sides of the brain instead of just the one side of the brain and become a convulsive seizure. So it's important to know what types of seizure your patient has, and if that's the case, that they sometimes can be just an impaired awareness, or do they ever spread to be a convulsive seizure. Here are some first-hand examples of what focal seizures look like. So the first focal aware seizure, where it's just kind of the daydreaming, frozen appearance, and they are able to recall the events that happen because they're fully alert. So a quote is, it is a pressure that starts in my stomach, then rises to my chest and throat. When it reaches my chest, I smell an unpleasant odor of something burnt. At the same time, I feel anxious. So a lot of times with seizures, there'll be this strange odor or an unpleasant odor that's associated with seizures and different types of seizures as well. And then the focal impaired awareness seizure. Susan's seizures usually occur while she's asleep. She makes a grunting sound as if she's clearing her throat. Then she'll sit up in bed, open her eyes, and stare. She may clasp her hands together. If I ask her what she's doing, she doesn't answer. After a minute or so, she lies down and goes back to sleep. So it's important to know that there's some kind of impaired awareness. Susan, in this case, may not remember this seizure, and she may not remember doing this. She may not remember sitting up, and she's not really responsive. The other thing with the focal impaired awareness is the involuntary movements, such as in this case, it was clasping the hands together. But it could be the rubbing of the hands or making lip smacking movements. Now we're going to move on to the generalized seizures. And remember, these seizures affect both sides of the brain. So we have the tonic-clonic, which is what most people think of when they think of seizures. It's the more convulsive seizures. We'll talk about absence seizures, myoclonic seizures, and atonic seizures. Tonic-clonic seizures were formerly called or referred to as grand mal seizures. So if you've previously heard of grand mal seizures, that's what we're talking about. It's the same thing, just a different terminology. So again, because it's a generalized seizure, it's going to start on both sides of the brain, and it includes a loss of consciousness. So that's different than our focal seizures. Tonic-clonic seizures usually last 1 to 3 minutes, so it's a very brief period. But if there is a tonic-clonic seizure that lasts more than 5 minutes, that's when it's considered a medical emergency. And we're going to talk about the 3 phases of a tonic-clonic seizure. The first phase of a tonic-clonic seizure is called the preictal phase. This is pre-convulsions. So this is where you're going to see signs of subtle personality changes. If the patient has an aura, this is the phase that the aura will be in. And basically what an aura is a subjective sensation or a feeling or perception that a person has that precedes a seizure. So this is different than a trigger because it's not necessarily an external flashing light or a tap on the head. This is more of a sensation that the person feels. This could be an unpleasant smell. It could be just a strange light that they see. It's not necessarily real, but they might just see a strange light in their head. Or they might start to hear like a ringing sound. And that may be a sign, an aura, that tells them, oh, I'm about to have a seizure. And then we're going to move on to phase 2, which is the ictal or the convulsive stage. So this is where the patient will experience a loss of consciousness, and it's going to happen very suddenly, and it's going to be this person's going to be completely unconscious, no awareness whatsoever. In phase 2, the patient's going to have both tonic movements that are followed by clonic movements. So the tonic movements or the phases are the stiffening of the muscles. So this can be the chest, the arms, and the legs, and these muscles are going to contract, and usually having something like an arched back in this phase. They also may have difficulty breathing, or they might stop breathing here. And this is just due to the stiffness and the contractions of the muscles in their body. And then in the clonic phase, and that usually follows the tonic phase, is where there's the spasms and the jerks of the muscles. So this is what we really think of when we think of the convulsions or the jerking movements. So this can be the elbows, the legs, or the head, and that they flex and relax and repeatedly happening. And at this phase, breathing may begin again because the muscles are starting to loosen, but they might still have difficulty breathing. Finally, and this should last only between 1 to 3 minutes, there will be the post-ictal stage. So this is when the seizure's over, the patient's slowly regaining their consciousness, and they might be confused and exhausted. So if you think about the amount of energy that someone's exerting during a convulsive seizure, the muscle stiffening and then the jerking movements constantly for 3 minutes, that's really going to exhaust a person. So they may really have difficulty kind of regaining their awareness. So it can take several hours to fully recover, depending on how aggressive the seizure is. On this next slide here, we're going to see a depiction of a tonic-clonic seizure. There's also a term in epilepsy called status epilepticus, and this is a tonic-clonic seizure that lasts more than 5 minutes, or a tonic-clonic seizure that continuously happens without rest in between, so a repeated seizure before that person recovers from the first seizure. And there's many causes that this could happen. So if someone's taking epileptic medication and they're not consistent with it, or they didn't take it, it could be a cause for this to happen. It could be brain trauma or tumors, or it could be also unknown. But this is the most dangerous type of seizure because this person is going to have continuous seizures, and it's going to be hard to break that cycle and to stop them from seizing. So in the case of status epilepticus and someone having repeated seizures or a seizure that lasts more than 5 minutes, we're going to be calling EMS immediately. So we need to have them get some intervention that's going to get them to break that cycle. And in this case, the treatment would be intramuscular or intravenous diazepam. Absence seizures are also generalized seizures in which that involves both sides of the brain, and they are characterized by brief, sudden loss of consciousness, so between 5 and 30 seconds, they're going to kind of have a blank stare across their face, glazed over eyes, and a fixed posture. So they are not going to fall down. If they're standing, they're going to keep standing. They may have rhythmic twitching or blinking of their eyelids, eyebrows, head. They might be making chewing movements. And in this case, the seizure is going to end very abruptly, and the patient's going to quickly return to consciousness, but they're going to have no memory of the seizure. So this kind of changes it from being a focal seizure, or the focal onset aware, which kind of has a similar blank stare. That person's going to be able to recall the events that occurred, where there's a loss of consciousness and an absent seizure, so they're not going to have any memory of the seizure. These are most common to occur in children, and they often grow out of them. And they also tend to occur when someone's just waking up or if the person's inactive. So a lot of times, if a person has absent seizures, doctors will suggest that they limit their periods of inactivity so that they do exercises and walking around, and they're not just sitting down and inactive for a long period of time. Next, we have myoclonic seizures. So this is a very different type of seizure. It's characterized by a rapid, brief contraction of body muscles. So if you think about what that means, a brief contraction of your muscle might make it kind of look like a sudden jerk. It could result in looking clumsy. So these are very short. They don't last very long at all, and someone looking at on the outside might not even realize that this is actually a type of seizure. So I put a video on the next slide of what a myoclonic seizure would look like. But these seizures do give us a little bit more of a risk in dental care because if we're working on someone and we have sharp objects in their mouth, sharp instruments around their mouth, or if they have excess fluid, we're actually in the middle of treatment and they do some kind of very jerky movement very briefly and comes on very suddenly, we might have an issue with dropping instruments or causing some issue. They might knock into our hand or we cause a laceration. So it is more of a risk during oral care. The last type of generalized seizure we'll talk about is an atonic seizure. And these also are a little bit different than what we usually consider to be a seizure. Opposite of a myoclonic seizure, which is that contraction, that brief contraction of muscle, the atonic seizure is an abrupt loss of muscle tone or abrupt relaxation of the muscles. So this might appear as a head drop, a loss of posture, so the person could, if they're sitting, they could fall over on themselves, or a sudden collapse if they're standing. So just a complete loss of muscle tone and they fall. And this is a little bit more tricky of seizures to treat with medication. Sometimes they don't respond well to medications. And again, this is a risk for us in oral care because if the head drops or if they're suddenly they lose that muscle tone and we have things in their mouth, we could have an issue with lacerations or injuries. So on the next slide again, I'm going to have a brief video showing an atonic seizure. Believe it or not, most seizures are not medical emergencies, so they tend to look really scary, but as long as we let them run their course, there's usually not a reason to call emergency services. Our main focus of managing a seizure is going to be to prevent the person from causing injury to themselves and maintain an open airway and make sure that the person remains breathing. First, we're going to have to recognize the signs, recognize that someone's having a seizure, and terminate any and all treatment. We're going to take, if we have something in the patient's mouth, we're going to take it out, especially something like gauze or a loose crown. Anything in the mouth, we're going to remove it. We don't want them to swallow it. We don't want them to hurt their teeth on it. To position the patient, we're going to turn them on their side. This is going to help maintain their airway. And then we're only going to move the patient out of the dental chair if for whatever reason, the dental chair is going to have them cause more injury to themselves. In most circumstances, the dental chair is going to be a great place for someone because it's padded. It has a headrest, and the chair itself is a padded chair. It's not a hard surface that they can hurt themselves on. But if there's some reason that there's something in the way and we should get them on the floor, you might move them to the floor. If they're in the dental chair, you're going to be removing any instrument tables that could get kicked or elbowed with an arm. Make sure that any instruments are out of the way. We're really just going to get everything out of the way from the person. I'm going to monitor the airway, breathing, and circulation. And we're not ever going to put something in a seizing patient's mouth. I think in the past there was a reason to think that someone could swallow their tongue and they would put something in their mouth during a seizure, and that's not the case anymore. So the seizing person is not going to swallow their tongue. It's impossible. They might bite your fingers if you try to put your fingers into someone's mouth, and they also could bite their tongue. So if you see bleeding coming from their mouth, it's most likely that they've traumatized their mouth some way on their own. But that's not necessarily a cause to do something about it during the seizure. You're still going to let it run its course. Here's a good list of do's and do nots for the management of a seizure. So first, our first goal is to protect the person from harm. So we're going to get anything out of the way that could potentially cause harm to them. If they're on the floor, we're going to be cushioning their head. The dental chair is probably going to have a cushioned headrest, so we wouldn't have to really worry about that. If they're wearing glasses, taking them off might be a good idea so that there's not any glass that's flying and breaking. And again, turn that patient on their side to help maintain their airway. If they're wearing really restrictive clothing, loosening it might help their exhaustion from having to fight that with the tonic-clonic movements, if that's the kind of seizure that they're having. And most important thing is to time the seizure. So we want to make sure that we're keeping record of how long it's lasting, because if we're going over that 5-minute mark, then that is grounds for calling the emergency services. And of course, with any medical emergency, we're going to document what happened and what we did to manage it. Some of the things that are important to say that we shouldn't do are things that people might think that you should do. So we don't want to restrain the person. A lot of times if the person's jerking around and moving around, our first thought is, oh, let me hold them in place to stop them from doing that. And we really don't want to do that, because it's just going to cause them to even have more exhaustion if we're putting extra exertion on them if we're trying to hold them down. Again, don't put anything in their mouth, or don't try to hold their tongue. They're not going to swallow it. And don't try to give them liquids. They're not going to be able to drink anything. They don't need to drink anything. And unless it's known that they're having trouble, they're not breathing, and that they're having an issue with circulation, then we're not going to be performing CPR unless we know that's the case. Finally, here's just one more slide depicting the do's for first aid or management of a seizure. So again, most seizures are not medical emergencies, especially if the person is known to have seizures and epilepsy. Usually they end after a minute or two, and usually there's no harm, and they don't require a trip to the emergency room. But there are specific circumstances and incidences that will require a trip to the emergency room and activating the emergency medical services. So we talked about a seizure lasting longer than 5 minutes. You'll be calling 911 for that. If the person is persistently confused or unconscious for more than 5 minutes after the seizure, that's grounds to call the emergency medical services. If they've never had a seizure and they don't have any, they didn't mark anything on their medical history about seizures or epilepsy, that's important. We should definitely get them to the emergency room, because we don't know really what happened. If they are having difficulty breathing still after the seizure, If they have repeated seizures, and that's that status epilepticus, that's grounds for calling the emergency medical service. And then if they are having an injury from the seizure itself, so if they fell, or if when they were having their clonic movements, if they injured themselves, if they injured their teeth, they're probably in the right place to get that taken care of. But anything other part of their body, we might need to call the emergency room if there's some kind of injury. Thankfully, there is treatment of epilepsy. There is medications that patients can take that will help control or reduce the amount of seizures that they'll have. And these are anticonvulsants usually. So a really common one is phenytoin or Dilantin. It's the same drug, just the brand name versus the generic. Unfortunately, they have some side effects, especially some oral side effects that I'll show you a picture of on the next slide. And then the other kind of medication would be more of an emergency treatment medication, someone who has status epilepticus, and that's that diazepam intravenously or intramuscularly. There's also surgical intervention. That is a possibility when the person is unresponsive to medication. And this can be brain surgery, so it can be a resection of their brain, partial resection, or they can do some radiation therapy. And finally, a newer treatment option is called vagus nerve stimulation. And basically, it's a implanted device, kind of like a pacemaker, that delivers signs to the vagus nerve. And it can have some side effects, but it is a treatment option that is definitely less invasive than surgery. So there is some precautions in the dental office. Something like an electrosurgery unit, which we wouldn't use, but oral surgeons and periodontists use electrosurgery units, or electric pulp testing for someone like a root canal specialist, or if someone's testing for vital pulp in the root of the tooth, would be contraindicated for someone that has this implanted device. Alright, so why are seizures important to us as dental health care providers? So, other than the fact that we need to be able to recognize them and manage them if someone has a seizure in our chair, there are some other applications to our practice. So, damage to the oral cavity during a seizure, there could be scars in their oral tissues if they're biting their cheeks or their lips. And there's a potential that they're fracturing teeth during the clenching of the tonic phase, so if they're really clenching their muscles really strong, or if there's a fall in the atonic seizure, if they fall, and they could potentially fracture their teeth on something that they fell. Gingival hyperplasia from that medication Dilantin or phenytoin, and on the next slide I'll show you what that gingival hyperplasia looks like. It's really important, if we know what their trigger is, that there's a lot of triggers at the dental office that could potentially be something that they would react to. So, like I said earlier, stress and anxiety, those sights such as the bright lights, sounds, different smells. So our best prevention, if we know their trigger, is to try to eliminate those triggers or eliminate the stress. And finally, if someone does have something like tonic-clonic seizures, we would be more likely to recommend a fixed appliance, meaning something that's not removable if they need to replace teeth. So this would be like a fixed bridge or a fixed partial denture rather than a removable partial denture. That's something that they would take in and out of their mouth. The removable just causes a bigger risk for something to be dislodged or something to get swallowed or cause an airway obstruction during a seizure. So if that's an option, trying to do something fixed rather than removable. Here is a great picture of what gingival hyperplasia looks like. So pretty much it's just an overgrowth of the gingiva. It's a hyperreaction, and it's not just in anticonvulsant medications, but there's also some other medications that can cause this as well. But this is a classic example of it. So you can see that it's more prominent in the anterior, and that's pretty common for what gingival hyperplasia looks like. But I picked this picture especially because if you look at their gingiva, it's not fire red. It's not, doesn't, if you probed it, it might not really bleed easily, even though it looks like it would. And that's a good indicator that this isn't plaque-induced gingivitis or overgrowth or just bulbous tissue. Because this tissue is pink, it's not really bleeding easily. This looks more like overgrowth than it does unhealthy gingiva. So thankfully, it only occurs in 25 to 50% of people that take it. Remember, with medications, not everyone experiences the side effects. So it's good to know. I mean, only 50% of people taking it won't get this. So just because they're taking it, you wouldn't automatically say, oh, they're going to have gingival hyperplasia. You need to make sure you're pulling all your factors in, all of your assessments into place to actually make that determination. All right, finally wrapping up our discussion on seizures. So we talked about the different types of seizures, the triggers, if they have an aura. So these are all the questions that we're going to be having to ask when a patient marks yes for having epilepsy or seizures. So what type of seizures do they experience? When was their last one? We want to make sure that they're taking their medications, so we ask if they've taken their medications today. If they didn't, that's going to be more of a risk for having a seizure in your chair. Ask them if they have an aura, or ask them if they have a trigger or if they know of anything to be a trigger. What usually happens, so what happens before and what happens after. And have you ever experienced a seizure during dental treatment? That would be an important to know, and also a good way to start a conversation to see what we can do to make that not happen today. And then finally, are you compliant with your medication? The book does mention some sleep disorders in this chapter, so I wanted to put a brief couple slides on them as well. So we'll just talk about some definitions here first. First, we have sleep apnea, which is an absence of breathing during sleep. That's usually associated with some snoring. It can also be associated with gasping of air during sleep because of the temporary loss of breathing. And it's often associated with obesity or with someone who has anatomical interferences. So sometimes the way the throat is shaped, if their tonsillar pillars are very closed off to the rest of the throat, and if the person has a very large tongue. The size of the tongue actually can be an indicator that someone's going to have more of difficulty with sleep apnea. So just because someone is a normal weight or even thin doesn't mean that they can't have sleep apnea. Next, we have insomnia. This is often caused by depression or anxiety disorders and often seen in the elderly. And this is difficulty falling asleep or staying asleep. And finally, narcolepsy. I'm sure you all have heard of this, and it's the irresistible, uncontrollable desire to sleep. So someone who can really just sleep at any time of the day, anywhere. They just fall asleep. It's not as dramatic as a lot of people make it out to be, whereas they just suddenly fall asleep. But it is that just irresistible urge to sleep at any time. There are some applications to practice that sleep disorders will have on us. So falling asleep during treatment can potentially lead to a respiratory obstruction. We talked about those a couple weeks ago. So falling asleep during treatment is actually not that uncommon. I've had several patients fall asleep while I've been cleaning their teeth. And this can be more common in someone with a sleep disorder. So if have insomnia and they aren't sleeping at night properly, they might be extra tired during the day. If they have narcolepsy and they can fall asleep anytime, anywhere, the dental chair is obviously a very easy place to fall asleep because you're reclined in a chair. And someone who has sleep apnea, might not be getting fully rested sleeps at night, so they might be tired during the day. They can be a little bit more agitated due to the lack of sleep, so that might be something that you would notice during your appointment. Sometimes patients that will be taking medications to treat something like narcolepsy, and they might have side effects, especially if they have narcolepsy and they're taking amphetamines. I actually knew someone who was taking the ADHD medication Adderall for narcolepsy, and Adderall is known because it's an upper to increase your vital signs, so that might be something that you would see if you were taking vital signs on someone with that medication. The next disorder we'll talk about is mental illness. So just because I had a statistic for epilepsy, I was curious to see what the statistic for prevalence of mental illnesses was. And I found, which wasn't surprising to me, that they're slightly more common than people with seizures or epilepsy. So the statistic is 1 in 25 adults will have a serious mental illness. So I think that that is pretty close to accurate. Seeing a lot of people, being a dental hygienist, you get to see, hundreds of patients throughout the year, if not 1,000 patients a year. So you get to see a lot of different people, and you notice that mental illnesses are more common than maybe we think. So a mental illness is a condition that disrupts a person's thinking, feeling, mood, and their ability to relate to others or do daily functions. They might have difficulty coping with ordinary acts or ordinary demands of life. So something like, vacuuming the living room might seem like a daunting task if someone has a mental illness. And they really can affect anyone. So it doesn't matter what age you are, if you're 10 or you're 70, what race you are, what religion or income. We see plenty of people of high socioeconomic status having a lot of mental illnesses. I'd almost think that we hear so much about people in the media having issues with mental illness. I'd almost think it's more. But we probably just don't hear about a lot of other people of lower socioeconomic statuses. And it's important to note that mental illnesses are not the result of some personal weakness in that person, a lack of character, or some kind of poor upbringing. So, it's truly a chemical imbalance. It's truly a mental condition. And I think the more that you experience and you see people with mental illness, the more that you really realize how real and they're not just something that someone's putting on. It's a real, true medical condition. And the good thing is that most mental illnesses are treatable. Mental illnesses cover a broad spectrum of different conditions. So some of the more common ones that I've encountered are anxiety and depression. So I actually see a lot more depression in older adults that they're taking medications for treating depression than I would have imagined if I wasn't in the profession that I am. ADHD or ADD, that's pretty common. Bipolar, if you're familiar with bipolar, it's someone who has periods of extreme depression and then periods of mania or hyperactivity. And some other common ones, not much more on this list here. Obsessive compulsive disorder, I think a lot of people like to say that they have OCD and they just mean that they're organized. But truly obsessive compulsive disorder, people have a true mental illness about needing to do things a certain way. I actually have a good story. We have a patient at our office who has a mental condition, and I'm not necessarily sure if he's been properly or or actually diagnosed. But what he does is scratches his gingiva because he feels like it itches. And so he's scratched the gingiva, which has caused a lot of recession. And he also would start wiggling his teeth. And in the course of about 6 months, he wiggled so much that he actually pulled out about 6 of his teeth. So my husband, he actually is who's treating him, had to actually, told him to seek help for the issues that he has, and won't really do any treatment on him because he's a very high risk of doing something to disrupt the treatment, since he has such a affinity for messing with things in his mouth. So unfortunately, it's actually really sad to see he can't stop pulling out his teeth. It seems like it's something that you'd be able to stop, and that's when I say mental illnesses are a really true medical condition. There are some applications to practice for mental illnesses. The medications that someone might be taking could cause xerostomia. That could increase their risk of getting cavities. So you might want to prescribe them a fluoride rinse, or consider that they use a fluoride rinse, or prescribe or give salivary substitutes for these people. There also might be drug interactions between the medication that they're taking and medications that we prescribe. Lithium is used to treat bipolar disorder and does have some drug interactions that we would be concerned about. Also, as far as oral manifestations, depression and bipolar disorder can lead to poor home care. So if you think about depression and the extreme depression that comes with one part of bipolar, the person might not have the want or the desire to have good home care. So they might not be brushing their teeth often, or when they do, not very well, and disinterested, and just don't have the real desire to do anything. And then in the extreme times of mania and bipolar, there's actually some people who've caused damage to their gingiva because they've done too much home care. So excessive amounts of brushing 6 to 10 times a day and brushing extremely hard has also been seen in bipolar. A lot of times we want to try to reduce the stress on patients, especially if they have anxiety. Someone with severe dental anxiety is considered to be a medical alert. It would require a medical alert sicker. So especially for someone with anxiety, we're going to make sure we employ those stress reduction protocols. And we want to make sure we're trying to gain that trust and establish a rapport with the patient before treating them. And then for some instances of some mental illnesses, there might be some unusual behavior that you might just need to kind of handle and be able to get through an appointment. So someone with schizophrenia, or multiple personality disorder, there might be, something said that just seems different or out of character for the person, might not be nice. But it might just be something that you have to try to handle and work around, as long as they're not or doing any harm to you or doing any type of harassment. If you know that they have a mental illness, it just might be something that you need to learn to handle and work around to get them through their appointment. Parkinson's disease is a disease of the neurons in the nervous system that affects movement. So a lot of times there's a lot of different stages of Parkinson's disease, and sometimes it develops really gradually, and it could start as just a little tremor in even just one hand, and then may progress to constant tremors or tremors in multiple hands. It might include the inability to walk. Someone with Parkinson's might, in the later stages of it, be wheelchair bound. And a big part of it, as far as what our application to practice, is that someone with Parkinson's disease most likely is going to have poor oral hygiene. Due to the inability to be able to perform oral hygiene on themselves, the inability to physically brush their teeth and hold a toothbrush, and even in the beginning stages, when they are doing that, having a tremor. So some other symptoms that might be associated with Parkinson's disease are burning mouth syndrome. They might have excessive saliva or xerostomia. And xerostomia is more due to the medications than anything. And if you have someone with Parkinson's disease in your chair, you have to really assess what stage they're at. My father-in-law has Parkinson's disease, and it's pretty progressed to where he's wheelchair bound and nonverbal. When he does try to talk, it's actually started to affect his vocal cords, so he can't project. He tries to talk, but he can't really project anything. So it's pretty debilitating in the late stages. But if it's in the earlier stages, and they're still walking, trying to assist the person as they come back to their chair. You don't want them to fall, especially if they have a caretaker or a loved one with them. Have them come back and help the person into the chair to try to alleviate the chance of someone falling. There may be the potential for orthostatic hypotension. Again, this would be someone who is being able to stand upright. And if they have a tremor that includes their mouth, it might be best just to get out a mouth prop. This would be best for you and probably best for the person. They know that they're tremoring, but there's nothing that they can do about it. So if they have a mouth prop that will hold their mouth in that open position, it can help you not have to deal with the shaking of their jaw and the potential for there being any kind of lacerations or accidents because of the tremor. And finally, in these patients, we want to be limiting our epinephrine. And finally, the last neurologic disorder we'll talk about today is Alzheimer's disease. And I'm sure most of you are familiar with Alzheimer's disease. It's a progressive brain disorder, and it destroys a person's ability to remember, their ability to reason, to learn, to make judgments and decisions, and basically, in more progressive stages, to carry out daily functions and activities. If you've ever met someone with Alzheimer's disease, it's just terrible. It's hard to see someone that used to be able to do and remember and talk about things. It's hard to see them in that state, especially if they're with a loved one who is cognizant. I can't even imagine being with someone close to me that has that. So for our application to practice, it just might be hard to communicate with patients with Alzheimer's. It's hard to get information from these people because they might just not remember a lot. So you might want to ask their follow-up questions, and you're not sure if you're getting the right answer because they just might not know or might not remember. So reviewing the medical history might be best with someone who is legally caring for them. As far as our patient privacy, as long as we have someone, if they're a legal representative for that person, we can ask them the follow-up questions, and we can review a medical history with a loved one. And it's also important to know that they might not be compliant with their medication. If they're in the earlier stages, that they don't need a caretaker 24/7, and they're still responsible for taking their medication, they might not remember to take it, or remember if they did take it, and then they take more than they need. So for someone with Alzheimer's disease, our management is to have frequent appointments. Remember, these people, if they're forgetting to brush their teeth, they might not have very good home care. And it's best when the office is quiet. It just helps if you quiet the noise around, it helps them to not get too disoriented and confused. Again, with the poor oral hygiene, you might want to prescribe or recommend a fluoride rinse or an antimicrobial rinse, an electric toothbrush just to help with plaque removal. And if you see that someone needs assistance with their home care, they're not performing home care as good as they should be, then you might want to see if you can talk to a caregiver or someone that they live with that can help perform it for them, or can at least make sure that they are performing it on themselves. All right, so thank you for listening. I know it was a long lecture today, but we had a lot to get through. So I wanted to give a little shout out to my helper. This is my little kitty named Olive. She helped me do your lecture for this week, so she's not with me while I record tonight, so you didn't get to hear any of her little kitten meows, but Olive is always helping me with your lectures. So we have a quiz this week on this lecture, Neurological Disorders, and if you have any questions before then, please email me, or you can make a comment on this voice thread and I will respond. If not, I will see you next week.